people. All right. All right. Good afternoon, everyone, and welcome to this session of our NeuroHIV seminar series. We have an exciting speaker today. It's Dr. Paul Regier, a research assistant professor at UPenn Center for Studies of Addiction in the Department of Psychiatry. He's a translational neuroscientist whose work sits at the intersection of psychosocial adversity, neurocognitive dysfunction, and addiction neuroscience. Backed by an NIH K01 Career Development Award, his current research integrates neuroimaging, computational modeling, and behavioral science to examine how environmental stressors, trauma, and co-occurring mental health issues influence regulation and recovery in opioid use disorder. So today's talk, titled Systems Level Vulnerabilities in Opioid Use Disorder, Psychosocial, Cognitive, and Neural Correlates, promises to offer a rich systems level perspective on how vulnerabilities across domains intersect to influence risk and recovery. So please join me in welcoming Paul, and we are excited to hear you start.
All right, had to find that screen again. Thank you very much, Raha. Excited to be here. This is, it's cool to come back. I know this is a joint between two different centers, but I got my independent funding path started here at PMARC, the Penn Mental Health AIDS Research Center, which sort of launched my independent funding career path, and allowed me to get this K01. So I give a lot of credit to these pilot programs that are available to get started in a research career. Okay, so everybody can see my screen, I'm hoping. I'm sure people will tell me if they can't.
Yes, looks great. We can see you.
All
And
right. All right, thank you. Okay, so yeah, acknowledging the Penn Mental Health AIDS Research Center for the pilot project concepts that I submitted to in 2019. And that was titled Neurocorrelates of Neurocognition Associated with Adherence to Antiretroviral Therapy in Opioid Use Disorder. So the goal was to have individuals with opioid use disorder and individuals with opioid use disorder and HIV to see if there's a compounding effect on neurocognition that might affect treatment or medication adherence. Unfortunately, the pandemic hit right around the time I got that award, and we sort of lost the collaborator partnership that we were going to have, and we're not able to really recruit people with HIV. We still tried, but we didn't have a lot of success, so we pivoted to just getting people with opioid use disorder. So I apologize in advance. There'll be nothing more about HIV from this point forward. So Ann Titleman, who's in the nursing school, or was in the nursing school at UPenn, she was the faculty sponsor and kind of got me started on this track of looking at addiction as more of a holistic framework and looking at the different factors that are impacting our brain, impacting our behavior. So I give her a lot of credit too. Anna Rose Childress is my primary mentor, or has been in the past, and helped get my K01 off the ground. And the other mentors that I have right now that are helping me with the K01 are Hassan Ayaz at Drexel, Reuben Gurr at Penn, and Kyle Campman at Penn. And then I want to acknowledge all of the research assistants and coordinators, project managers, and other people that actually run the day-to-day trials and do the recruitment. And without them, I wouldn't have any data. All right, so we've probably all heard about opioid epidemic in 3 waves. Of course, it started with a rise in prescription opioid overdose deaths starting in the 90s, early 2000s, followed by a rise in heroin overdose deaths after we started to regulate more so the prescription opioids. And then the sharp rise in deaths associated with synthetic opioids like fentanyl has been the primary problem, and has increased deaths to over 100,000 per year at this current stage. We're in the middle of a fourth wave that's occurring, which is the use of both cocaine or other stimulants like methamphetamine co-occurring with opioids. And this is having the effect of causing stimulants like cocaine. They increase heart rate and blood pressure. Opioids suppress respiratory function. So this can lead to just disastrous effects. And one study at least showed that people who use both of these drugs had more than twice the hazard rate of fatal overdose compared to people who only use opioids only. And we already know how deadly opioids on their own are. So this is an upcoming problem, not to mention all the other contaminants that are in the drug supply right now as well. Thankfully, we do have good medications for opioid use disorder. Methadone and buprenorphine are helpful for reducing the risk of overdose. Here on the y-axis, you see probability of continuing without an opioid overdose, so higher numbers are better. So this top line are people who are using buprenorphine or methadone. They have a higher probability of continuing without an overdose. And then these bottom lines are people receiving no treatment or have just come out of detox, and they have a much higher rate of overdosing. These medications for opioid use disorder also reduce all-cause mortality. So if you're in methadone treatment, you begin methadone treatment, the probability of dying from any cause drops within the first few weeks and stays pretty low. But if you just come off of methadone treatment or you choose not to do methadone treatment, you actually see an increase in rates for the first few weeks. So that's a really sensitive period right there between 0 and 4 weeks, that first month, where people are very vulnerable after choosing not to use, choosing not to be treated with a medication or coming off of those medications. Okay, so the problem is, though, and this is just a screenshot from NIDA, problem is that less than 20% of people with opioid use disorder are actually getting them. And it's due to a number of different factors. There's isolation, people in rural communities. It's more difficult to get buprenorphine because you have to have a special license. There's stigma. I don't want you to know that I have a problem. And there's and then there's just underrepresented minorities just face more barriers to access medical needs in general. So there are barriers to getting it, but this rate is much lower than any mental health rate of medication. I was working on a different paper or a different talk, and like depression rates, it's like 60%. People who have depression, about 60% of them are getting treated for it. And anxiety is around like 50%. So it's really low in people with substance use disorders. And the other issue is that once you get on a medication, the likelihood of staying on that medication drops really quickly. Within a few months, so within the first 3 months, you're almost at 50% probability of remaining in treatment. And then by 6 months, that's dropping below 50% to, I don't know exactly what that number is, but it's around 35, 40%. So we have trouble getting people on medications in the first place, and once they're on, it's difficult to keep them on. So this is where the pilot project started, and this was after talking to David Metzger about this, is that we have an issue with medication adherence. And one of the things that we found that is associated with lack of adherence is neurocognitive difficulty. So making decisions, remembering things, being able to switch between tasks. So just general neurocognition decline is associated with worse adherence. So this is in a general population, not an OUD population, not any sort of mental health population, but generally, if you have, quote unquote, impaired neurocognition, there's a drop in adherence to medications, but that significantly drops when you add complexity to the regimen. And I'm just going to grab a laser pointer. So if the medication is requiring them, if they have both an impairment in neurocognition and they have to take, a pill 2 to 3 times a day, that adherence drops significantly. So it shows that we should have simpler methods in the first place. So they found that that executive function and memory and attention were associated with this lack of adherence. And this will be where my focus is, along with another one that I'm going to add here, which is complex cognition. That includes, higher order cognition like decision making, cognitive flexibility, switching, social cognition, metacognition, and we'll talk about kind of all of those a little bit later. So yeah, this is how the whole project got started, to understand how brain and behavior affect neurocognition. And so this talk is going to kind of end at that point, right? This talk is more about a mechanistic standpoint. So eventually I want to apply this model, the system, to predicting outcomes, but right now it's about trying to figure out the mechanistic and other factors that are driving difficulties with neurocognition. But it's not just neurocognition. There's a bunch of other factors that are associated with clinical outcomes like non-adherence, age and race and class, socioeconomic status, health, mood symptoms, social function. All these things are affecting our clinical outcomes in our participants. And so in order to try and understand that, and what I've been trying to apply this past year is understanding this data from a more systems level approach. So I wanted to set up a conceptual framework that we can kind of hold on to throughout the talk. But I also wanted to stop. I'm not sure if there are questions, wait till the end, or if you want to jump in here to ask any questions, but I want to stop and make sure we're okay at this point. Okay. I don't see anything, but I also can't see chat. All right. So a systems level approach is trying to look at the problem in a more holistic fashion. So looking at dynamic and interdependent factors rather than just looking at one single factor that might be contributing to some outcome. It emphasizes relationships and feedback loops, moves beyond simple cause and effect models to look at those interacting effects. It's looking at how changes in one part can have ripple effects across the whole system. And, it's also like my interest is to identify underlying causes rather than just managing symptoms. So really getting at those root causes. And then hopefully the idea is that by understanding these system structures, the approach will help to create interventions that are more sustainable over the long run. Okay, so to set up the framework, this is not the only way to look at this. So I just want to point out that, this is my application of this systems level approach. So it could definitely be interpreted in different ways, but this is potentially one way to look at it. So over here, we have factors that are associated with like who I am and what I do, like my job, education, the culture I was brought up in, my social support. That's going to affect how I feel, how I react and cope, my mood symptoms, my emotional regulation, my behavior regulation, and those will affect how I make decisions overall. And that's all tied to neurocognition. So this is our outcome point right here. This will be our independent variable in this systems level approach. And then these cognitive factors are all underlaid by neurobiological and biological factors. And we're using a number of different tools to get at those factors. This particular analysis is only using FNIRS, but we're going to be adding in different metrics in the future. And FNIRS is functional near infrared spectroscopy, and I'll talk a little bit more about that later on. So of course, in reality, the systems level approach, you have all these feedback loops. So if you, change how you feel and react, that's going to change potentially like what you're doing or what job you might want. What decisions you make are going to change how you feel, so on and so forth. But for the simplicity or for the sake of this particular talk and analysis, I'm more looking at the ripple effect. This leads to this, and this leads to this, and it's underlain by this. Okay, so my PMARC pilot, Penn Mental Health AIDS Research Center pilot, I just published the sort of the main findings from that pilot last year, and that paper is called Factors Associated with Cognitive Flexibility in People with Opioid Use Disorder. And so what ended up happening in the pilot is that I collected data from 32 people with opioid use disorder. And then PMARC graciously was able to, because they have a number of different pilots, they were able to pull up some control data, some age and sex and race match control data, so that I could do some comparisons. And because these pilots are using similar batteries or similar core features of the center, like a cognitive battery, we're able to directly compare scores from this pilot to other pilots that have collected the same data. So in the pilot, we had 32 individuals with opioid use disorder and 15 that I'm calling non-substance using controls. Because we didn't exclude people if they had a mental health issue. We didn't exclude people if they were taking medications for mental health, because I'm interested in how all of those things are affecting outcomes. I feel like a much more real world application of what we're actually seeing out there if we are studying all of these different factors. And so the main findings are that we found significant differences between controls and opioid use disorder in conditional exclusion task, which is a cognitive flexibility task, and working memory, which was the NBAC task. And looking at a number of different factors, this is still when I was kind of in this mode of looking at how one task relates to one or two factors. In this case, we found that only flexibility was associated with impulsivity and social function. So the higher impulsivity a person has, the lower the cognitive flexibility they had. And the higher the social functioning they had, the better the cognitive flexibility they had. So just kind of breezing through that pilot quickly to get on to the next part, but wanted to show the foundation of where this whole project started. All right, so study 2 is from the NIDA K01, and this grant is called Integrating Brain, Neurocognitive, and Computational Tools in Opioid Use Disorder. And it's to characterize, initially I was focused on executive function, but it's kind of broadened out to be more about just neurocognition as a whole. So looking at executive function as one domain, but also memory, and also the other one that we talked about, complex cognition or higher order cognition. And eventually to predict clinical outcomes. So I did a preliminary analysis about halfway through. We started in 2023, and we've collected data from over 100 participants so far. And one of the reasons, again, why we were able to do that is because our door is fairly wide open. You can have mental health disorders, you can be taking medication. the study sessions themselves are short. So they come in for about 3 hours. They take surveys, they do a neurocognitive battery, and then they do another neurocognitive battery, but while we're capturing brain data with FNIRS. So about 3 hours, we get all of this data, and it allows us to look at a number of different factors and see how they all interrelate. Okay, so because we're not screening out or matching on any sort of variable, we're going to see major differences in the groups, and that's fine because we want to know how these are affecting our primary variables. But they do match on age, just barely. They differ in sex at birth. So there's more males in the OUD group, and there's more females in the control group. Race is equal in both groups, but this is a bit of an issue because it doesn't really represent Philadelphia. So in the next couple of years, we'll be increasing our recruitment to get a more diverse population. And then income, so like class and I should, just income is much lower in the OUD group. So 88% are making less than $25,000 a year. About 60% have completed high school or less, while in the healthy or the control group, about 90% have had some college or more. About 50% have some form of childhood abuse. Depression is really high, depression treatment. The only one that kind of flips here is alcohol use, and this is more moderate alcohol use in the controls, whereas the opioid use participants are using illicit substances like stimulants and opioids. Okay, so that's not all the factors we capture. We captured a lot of different factors. And one way to deal with a number of different factors is to run things like factor analysis or a latent class analysis. So for binary or categorical variables, a latent class analysis makes more sense. So I grouped these into conceptual categories and made sure that they actually fit the latent class structures. But so I included things that were environment or SES, like income, education, employment, disorders and conditions, like all these mental health disorders, polydrug use, and trauma. And so we can take all those factors and make 4 different classifications that significantly differ between the 2 groups. So we have our abuse class, one with higher abuse versus lower abuse, and that significantly differs. We have a group with lower SES and higher SES. We have a group that is struggling more with mental health. This is a proxy of struggling. So we have people that are receiving medications for mental health, and that correlated strongly with higher mood symptoms like depression and anxiety. So we're calling that people who have more struggles with mental health. And so we have individuals with higher mental health issues versus lower. And then we have our drug use classification, higher versus lower. So those are our latent class variables that we're going to pull forward with us. So let's put those into the conceptual framework. So we have our mental health class, our class, our drug use class, and our abuse class. All of those are significantly impacted by opioid use disorder. Okay, so next up, that's more of the, I guess, the who I am, what I do category. Next, we want to look at the how I feel, the more subjective and some behavioral type of factors. So we collected a number of different factors, and these are all continuous variables. So with continuous variables, it's better to use an exploratory factor analysis or something similar to that. We can also group these conceptually into things like mood symptoms and well-being, regulation, drug use, and cognitive domains. And you'll see that there's a number of factors that are highly intercorrelated. So that tends to be any of the survey variables that we have. If you have higher depression, you tend to have higher anxiety. You have less regulation and higher drug use. So those things all kind of travel together. And that's why you're seeing these big red square boxes. And then over here is the cognitive factors like attention, emotion recognition, memory, so on and so forth. And they all are highly intercorrelated. What I'm really interested in is this block right here, where the cognitive factors are interacting or correlating with the more cognitive factors with the subjective factors, to put simply. So we'll create, sorry, we'll create factors first and then look at those relationships. Because you can, I mean, you can look at these giant matrices, but then you're correcting by, like 100 here. And then something might pop out and it might be interesting and it might relate to this, but it seems sort of random and it doesn't seem super effective in my opinion. So we can break down neurocognitive domains into conceptual or neurocognitive factors into conceptual domains of executive function, which includes things like working memory, attention, inhibition, and switching. These are all the different tasks that we use to collect these, which I'm happy to talk about, but I'm not going to go into them now. And then memory, we had 2 long-term memory tasks that were included in this memory factor. And then complex cognition included decision-making, adaptability, social cognition, and visual spatial processing. So we have 3 neurocognitive factors. And then from the rest of this data, we create 3 additional sort of subjective behavioral factors. So we have mood symptoms or well-being. I'm calling this a mental health well-being factor or MH factor, which includes these variables. Again, happy to talk about all those. Regulation, which includes these variables. Drug use, which includes these variables. So these were conceptually defined, but then in the exploratory factor analysis, they loaded on strongly onto these factors. And I have a slide as an extra thing that I can show if anybody's interested in how they loaded onto these factors. Okay, so how do the groups compare on these factors? How do they differ? So we ran an ANCOVA, which includes covariates of sex and age, and looked at group differences. And we saw that the OUD group had significantly lower complex cognitive scores, had lower memory scores, and had lower executive function scores. We also saw that for the other factors, the subjective behavioral factors, mental health and well-being was they had more mood symptoms and less well-being in the OUD group. They had higher amounts of dysregulation in the OUD group. And of course, they had more drug use. And so this is just showing there was all group effects were greater than 0.001. I was showing this up here because there's also some other effects going on, which we can talk about again, but age is a significant factor in complex cognition. So it's important to include it in this analysis or in this analysis. But controlling for it doesn't take away the effect. Okay, so now that we've reduced our variables down into 6 different factors, we can better look at how they correlate together, get a more clear picture. So we see that age, again, is a significantly correlates with complex cognition. So the older you get, the lower the scores you get on the complex cognition factor. Higher amounts of mental health symptoms and lower well-being associates with lower cognition, complex cognition. Same with dysregulation, higher dysregulations associated with worse complex cognition. So that was interesting that these factors were explaining the complex cognition more so than executive function. But we did have 2 correlations that survived correction. And this is all, this is 21 different pairs of variables that we corrected for. So multiple corrections using Bonferroni. They survived, so drug use was associated, higher drug use was associated with executive function and memory. Okay. All right, so we're going to keep filling in this conceptual framework, the systems level conceptual framework. Now we have all of these different correlations that we just talked about. And of course, they all they also have intercorrelations as well. But right now we're just focusing on this kind of ripple effect. So going from left to right. And so now we need to see which of these classes, if any, are associated or can predict any of these factors. So we're going to, first I ran a bootstrap analysis to look at the probability that one would predict a specific factor. And if it scored above 80% or higher, then it would be kept in the analysis. And so after running the bootstrap analysis, we ran a stepwise linear regression, and these are the results. So mental health class and our SES class seem to be the strongest predictors, the most robust predictors of both our mental health factor, or well-being and mental health factor, and our regulation factor. Drug use, and these are, so these are showing effect sizes over here. So these are very large effect sizes. Drug use class, this is also significant. It's just a much smaller effect size. It's meaningful, but it's just not as robust in this particular analysis. We're looking for really highly robust effects. Same with regulation. So with the drug use factor, there was only group that highly predicted drug use, and that's not too meaningful because, of course, we have opioid use disorder group that's using drugs and non-substance using controls, and it's right there in the name. And then, of course, our drug use class, the ones that are using drugs are going to be using more drugs, right? So not very meaningful. So we're not going to focus much on this relationship. And then surprisingly, again, group was the strongest predictor of our cognitive factors. So higher order cognition, or complex cognition, we've been calling it, and memory. So now we can fill in the left side of the graph. We talked about why this is not a very strong or a very meaningful correlation to keep in there, so we can drop that out. And this is just showing us that those that are being treated for mental health have the highest mood symptoms and the least amount of well-being. So we can also drop out that one because it's just a confirmatory stat. So our overall picture to this point looks like this, where we have mental health and SES driving a lot of the subjective experiences and some drug use, and that these factors, mental health and regulation, are seem to be driving, or at least highly correlated with, complex cognition. And so, I mean, intuitively, some of this sort of makes sense. If you don't have access to a lot of resources, you're going to have probably less energy to regulate emotions. You might have higher depression and anxiety scores. And if you have all of that subjective emotional experience going on, it's going to be more difficult to do complex decision-making and switching tasks and more cognitive types of activities. Okay, so the final piece is adding in neural correlates and calling this proof of concept because we are using one of our tasks from the task battery. This is the one that we got, all processed by the time of the preliminary analysis that we submitted for a conference. So it's limited in its predictability and translatability, but it shows, I think, the importance of adding these type of variables. Okay. So I see some things going on in chat. I think I can answer those afterwards. If you want me to stop now, I can. Um, so the task that we're going to be looking at is Tower of London. It's a decision-making task, and we are collecting FNIRS. So FNIRS is this kind of very easy to use, cost-effective neuroimaging technique. And in this case, we're just using a headband that has 16 optodes and allows us to collect superficial data from the prefrontal cortex. A lot of times it's an augment to fMRI or something like that, but I'm interested in whether just even adding in some neural data is going to help improve these models. So the other thing about FNIRS is that when we did the pilot, we were also collecting FNIRS with the pilot, is that it was difficult to get participants over to our lab. So this is portable too. We were able to take this over closer to the participants where they were receiving their methadone. And we were able to basically take the technology to them so we could collect this data. So it has some, clinical applicability type of applications as well. So the task itself is pretty simple. We have a mixed condition and a same condition. You're mentally trying to figure out how many moves it takes to make your board look like the target board. So this one, of course, is the same. So there's 0 moves. And in this one, you would count how many moves it takes to make this look like this. And in this case, you would move the green over here and you move the blue here. And you're doing this all in your head. And you're not moving these things physically. So it adds a level of cognitive load. So this is higher cognitive load. This is lower cognitive load. So this one, they would answer 2 when a prompt comes up, but we're measuring the brain activity while they're looking at the problem and trying to study what it is they need to do, or like working out the problem in their head. Okay, so here's the results of the data. Looking at quadrants, so looking at left lateral, left medial, and right lateral, we can see that there's not a lot of differentiation or interaction between groups and conditions. What I see mostly is that one group tends to have just higher activity or maybe higher brain health in the frontal cortical portions where blood is able to get there better because FNIRS, I haven't talked about the technical aspects, but it's a proxy of getting the hemodynamic response. So it is measuring, it's a proxy of blood flow. So the controls look like they have more blood flow going to their frontal cortical regions, while the OUD group has significantly less. And the only interaction or slight interaction was this one here, where the OUD group was showing a little bit higher activity in the mixed condition compared to same. So we can use this, even though it's not showing this differentiation, it's giving us a biological or neurobiological metric that we can add into the model to see if this adds any, it explains any additional variance in the model. So first we'll test and see if any of these quadrants, activity in these quadrants, can predict any of our cognitive factors. Okay. And what we found is that there's an interaction between group and FNIRS activity or brain activity that predicts for complex cognition. And I'll show you what that looks like so that it's less abstract. So on the x-axis, we have the right lateral FNIRS activity, and the y-axis, we have the complex cognitive scores. And so as OUD has higher activity in that region, the right lateral region, they actually show less complex cognitive abilities. And the opposite is true with non-substance using controls. So it's a little odd. We have some ideas about why that would be, why during the same condition, again, this is during the same condition, why that would correlate with cognition at all. We think it might have something to do with daydreaming or non-associated thoughts. There's some evidence in the literature that it suggests that as you get older, you have more non-associated thoughts that then are associated with worse cognition. So that could be what's going on here. But the important thing is that we have a signal that we can test in the model to see if it adds any extra explanation. And we focused on the right lateral regions just to simplify the model, because that's the one that kept popping up across the board. So nothing was predicting executive function, and there was a sort of, connection or correlation between brain activity and memory. So we took this original model, which was just group predicting higher order cognition, and we added FNIRS to it and found that adding these signals from the right lateral prefrontal cortex during the same condition significantly improved the model above and beyond group, age, and sex. And I showed you the plot already to see how those associations work out. With memory, adding in the FNIRS data or brain activity did not add any additional explanation. Okay, so that's our final piece. We have brain now that is associated with complex cognition, but not memory or executive function. So I'm going to simplify this model even more because we have quite a few things that don't necessarily need to be in the model. This connected to this, we already know why that is not meaningful. Abuse, surprisingly, the trauma factor did not have much of effect in this model, but I'll kind of talk about why in a bit. And so I'm basically taking from left to right the path that had all the different tools that we included in this model, from our surveys to our cognitive battery to our brain data. And so that makes a path and a model that we can try to replicate with the remaining participants that we're going to get in the next couple years. So we'll test this model to see if it's, truer than just a hypothesis, I guess. And so we can basically say overall with this model that struggles with mental health, struggles with SES are related to difficulties with subjective feelings and dysregulation, which are associated with difficulties with decision making. And this might be driven by some, brain differences in the right lateral prefrontal cortex. And then as an exploratory, we did see that this mental health class was associated with higher drug use. So we can explore this pathway and look at how this interacts with executive function and memory. My thinking is that we're going to need more subcortical metrics because previous research that I've done has shown that abuse and trauma are associated with differences in more subcortical dopamine type of regions, like the ventral striatum, midbrain, and amygdala, in those sorts of subcortical regions. So I think that by capturing those and adding trauma in here as a moderator, we might see this model working for these other cognitive domains. All right, so that's it. So the overall summary is that the class and mental health seem to be explaining subjective experiences and general well-being and emotional and behavioral regulation. And that these are associated with worse cognitive function, especially complex cognition, and that there was a moderation by right prefrontal cortex activation, and it was adding a unique explanation of variance for higher order cognition, or complex cognition as we were calling it. And so here's that path again. And then the hope then is that, one, that this whole model can predict outcomes, and that'll be something that's tested hopefully in an RO1 that I'm planning. And then the other idea is that interventions can target one or more of these classes or factors to understand how these affect clinical outcomes. So the idea then is that you can tweak different parts of this, if give help with housing, it can be something as simple as like connecting with the city um, uh, organization that I'm forgetting, long acronym, but they help individuals get housing. So it could be as simple as doing that, plus, trying to help with emotional regulation. It could be that there needs to be a medication on board. It could be that we need neurofeedback or some sort of neurostimulation, or just brain training. So all these are kind of on the board as potential interventions, but I think it's not just one thing. We're going to have to do a couple different things in order for us to actually treat the person because they're dealing with so many different things. Um, okay, so that is it. That was my talk. Thank you all for listening.
Thank you. That was really wonderful.
Thank you.
Does anyone have any questions? Leah has so many. Leah's
Well, this was a fascinating talk, and it's kind of fun to see the FNIR stuff because I see Joan on here as well, who turned her screen on, but we've been working with Roe Holzer, who's been doing FNIRs, but in the context of kind of dual task interference. So that was something. But what I noticed is when you were controlling for certain things, I think you said age and was it sex? But I didn't hear years of education, which is, cognitive reserve and really understanding, do those two groups differ on that factor? And that if that was adjusted, that might mitigate some of the issues. And then my other thing is that, you're grouping some of these tasks. I think complex cognition, you had decision making, and I think there was a social processing task,
Yep.
maybe. And so, while you're grouping all of those things, they have right? Like it would be nice to know, is it really kind of decision making needing frontal? Is it social processing needing frontal amygdala? And which one might be a bit stronger? Because they definitely tap different things. So kind of honing in, like, so where you're starting and seeing it is social cognition, but what aspects of it are being more pronounced, I think will give you a little bit more you know, of where to focus on a little bit more than just kind of grouping it all together.
Gotcha. I think so, and I understand that. I understand that appeal. I think that's what I'm trying to move away from is this idea of focusing on one single cognitive factor that
Sure.
someone's dealing with and grouping it together with something like education. And those two things are going to correlate. There's no question, right? You're going to see education and SES are going to be associated with lower cognition. That's just, especially in this group. So, I mean, to me, it seems like that is just taking away from the entire, model systems level approach, which is talking about all the different factors that they're dealing with. Because just changing the cognitive factor isn't going to make them better. It might help, but it's not going to change their lives in a way that gives them better well-being and better mood symptoms in the future and have better clinical outcomes. So,
Sure, but if you're controlling for age, right?
yep.
That is so like you think about the factors that mostly influence cognitive function, right? And age and education are kind of two of them. So again, just
Mhm.
trying to understand when you're looking at OUD versus the other groups, that if you
Yep.
account for kind of cognitive reserve, does that attenuate the kind of drastic differences that you see?
Oh, shoot. You know what? I didn't. Okay, let me go back. Yeah, so let's go back here to the classes. I know this
Sorry.
is a lot. I apologize.
No,
And still,
this is great, and I think we're very similar minded in thinking through constructs and not individual tests. But
right.
um, so it was great that you looked at executive function; those tasks made sense. I think it was just more on the other end with the complex cognitive function.
Mhm.
They're even though you're pulling them together, they're still different to me, it's not just cognitive function. Each of those complex tasks require different different brain, regions.
Gotcha. Yeah, that's a good point. And complex cognition, I did kind of group it together because those in a exploratory factor analysis, it was lumping those together. It was
Got it.
lumping executive function together. It was lumping. Sometimes memory would go in different places.
Yeah.
But those tasks were lumping into like a single category, and it was like, how do these relate? So it'd be good to talk more about that because cognition isn't my background. I'm still learning more cognition. So yeah, it would be good to look more in depth at those because it was kind of lumping together. But and like I said, this is all one way to look at it. And so there could be different ways to group these things together. But I did want to point out that the class classification, which is what I'm calling the SES or environmental class, included education, employment, and income. And so education was significantly different. Most individuals who were, but you're saying that you should include that in the model, right?
Well, I think when you're looking at, like, say, cognitive differences or so you're looking at group differences here.
Yeah.
I think you have to, at minimum, account for age and education. If there's education differences between the two groups, and we know education is highly related, and so this comes more on the cognitive outcomes end of things, where we typically you would norm your data accounting for things like age and years of education. We can consider sex as a biological variable, and then race
Right.
is and ethnicity are very complicated. So
Yeah.
I don't like including that, but education is going to be a big one.
Yeah, and so when we ran these the stepwise linear regression models, all those things were in the model. So it kicked those out. It was saying that for higher order cognition, for some reason, group was a better explainer of complex cognition than any of those other factors, which was not the case for these up here. So the mental health factor and the regulation factor were all predicted by SES and our mental health struggles classification. But for complex cognition, executive function, and memory, group was the best explainer. So I think it was just the whole person was kind of encompassed in that. Is really, I don't know. I don't exactly know how to explain that that's better. If I took group out, then I would imagine class or mental health would best predict complex cognition. But I wanted to see if there were classes that were explaining these factors beyond group, not just group, but beyond group. If that makes sense.
Can I say one more thing, Raha?
Okay.
Yep.
Sorry, because it also could be due to the way that you're doing your regression models, right? So whether you force enter manually, so you may want to do some manual approaches, because otherwise the stepwise it's going to take, right, and it's going to dump out. So you may want to kind of play around more on a manual approach to see what stays in and what gets kicked out. That's it.
Yeah, no. I definitely did that. I ran them forward and backward. The bootstrapping was the step that would show whether anything else was showing up probability wise. So when you run a bootstrap, it'll show the best predictor at the top, which one comes at the top, and group just won out completely. None of these other classes, none of these other ones were, because I was worried about that too. I was like, why is group there? So I took group out and I looked at the different classes that were driving it. I put group back in, group still won out. So yeah, I went through all those steps, and it group still won out in this particular data.
Thank you. You have some other questions in the chat. Do you want me to read them out to you, or want to speak
Sure,
on?
if you want, or I can read them out, whatever you want to do.
You can go ahead and read it. I just didn't know what you saw on your screen and what would be easier for you.
Yeah, I can do it. Is there any data on cognitive impairment associated with drug prescription and its differential spectrum with sensitive attributes? So drug prescription as in like opioid prescription? pills, like opioid pills, pain pills? Is that what you mean?
Yeah. Hello. Actually,
Yeah.
I was a little bit late, but actually, yeah, this study and is quite interesting. So actually, I'm still in a kind of learning curve. So in one on the one hand, actually, from substance use disorder, the kind of perturbed in a way of plastic kind of adaptation or maladaptation, that what's changing. But actually, on that clinical medication kind of prescription, also whether just actually non drug free kind of on that ways, but also whenever there comes chemical or a kind of any actually available and canonical pathways,
Mm,
avenues of medication that through clinician,
mm,
doctors, they actually I'm at Morgan State University in Baltimore, so there health disparities and racial disparities and many aspects of differences and differences in our genetics level spectrum, also in our healthcare level, higher level of careful, expectedly careful differential prescription. So, kind of the conjugated adaptation and plasticity from that exposure to substance use disorder and around there, and how there comes differential,
yeah.
especially carefully differentiated medication. So they actually, whatever your thoughts are, well, and also with some already collected sampled data, any search will be appreciated.
Sure. Yeah, so the goal would be to eventually get a large enough database to look at individual factors like which medications they're taking. So if we go back up to that large thing, so you can see that depression meds are in there, anxiety meds. This is other disorder meds, but that includes PTSD and
Mm-hmm.
sleep and some other things. So yeah, there might be individual medications that are having more of an effect down this pathway, but that will be something to explore kind of in the future when there's more data. Right now, we are very much, I am very much interested in just understanding at kind of a bird's eye view whether taking medication in the first place. It was surprising to me that those it shouldn't have been, but those taking medication and versus those having just a diagnosis were struggling more with mental health, had higher symptoms. So I found that kind of interesting. But all right. So let's see. Do we have more time? What time is it right now?
Thank you.
I think we are at the hour, but
Oh, okay.
I guess that means I get to ask the last question. So I did my PhD at Drexel, so I'm really familiar with this one and the FNIR work back when Dr. Honorall was working on it. I had never, back when I was there, this was a while ago, it hadn't reached a clinical stage yet. So I'm really interested in that and its application. And the data that you were using and showing, did you see any sex differences or anything that needs to be corrected for in that data?
Hmm. I don't think so, but I would have to check with our engineer. He did most of the differences between the groups in the brain, and then I extracted all of those and used them. But I don't remember seeing any sex differences, but there could be. So sorry, I don't know.
Well, we'll just have to keep an eye out on what you publish
Yeah.
and when you start incorporating other imaging measures as well. I thought it was really nice to see that. Thank you.
Yeah, I mean, Hassan has been great, and he has started to use FNIRS in the clinic as well, where he's using it to do like TBI. So I'm hoping that because this is just a 3-hour assessment, that you'd be able to take this into a clinic if the model works out, right? If you can tweak different parts of the model, improve outcomes, this could be a clinical assessment type of thing. That's
Yeah.
the long-term goal.
that's really easy and portable and inexpensive to use.
Yeah.
Yeah. So thank you. Carolyn put a footnote in the chat that next week's speaker is going to be on eco HIV model. So that'll be a nice switch too. But I love how everyone's work kind of overlaps in all the different applications. So thank you for speaking today. I hope you come back and speak again soon.
Thank you very much for having me. It was great. It was a pleasure.
Bye.
Bye.
All right. Thank you.